Thank you, Tom. Nick, I have to start off by saying that I'm really sorry you drew the short straw, because I'm not sure there's any way you could win such a debate as this. But your experience, I'm sure you'll find something to say. But nonetheless, let me try and make an argument for why I think severe acute pancreatitis must be treated in a specialist centre. But I'm going to start off slightly differently, and I'm going to say that one of the big things about a health system is that if patients are treated at the wrong level of care, it really defines one of the real reasons that we have inefficiency. So let me use a simple example like appendicitis. I mean, treating uncomplicated acute appendicitis in a in a referral centre makes absolutely no sense. It's a huge inefficiency. But if you treat a patient with appendicitis and 4-quadrant sepsis in a district hospital and end up with intestinal failure, the significance for the patient survival, but also the cost escalates dramatically. So here you can see a laparoscopic appendectomy. Patient does really well, easy operation, but this kind of complicated appendicitis ends up with an abdomen like this. So is this what we want in acute appendicitis, in acute pancreatitis? And so the question really is, does this apply to acute pancreatitis? Can we draw similarities? And if we can we, like appendicitis, determine who should be treated at what level of facility? And if it depends on the severity of the illness, can we actually determine with any degree of accuracy the severity of acute pancreatitis? So let me say that it's about a quarter of patients with acute pancreatitis will develop severe disease associated with organ dysfunction or organ failure and require admission to an intensive care unit. Now, this whole discussion started a long time ago in this study from the Mayo Clinic, which really started to tell us that there were different degrees of severity. And what was interesting, there was a group of patients who, although they had some evidence of severity, they had a similar mortality to patients with mild pancreatitis, but a much worse morbidity. And so it starts to reflect this whole journey we've had on determining severity. So there is evidence that we can accurately predict the severity of acute pancreatitis in the clinical context. And I want to here just start to unpack this, the fact that there's predictors and there's stratifiers. Predictors tell you about the future, they tell you what the likely outcome for the patient is. But stratification talks about where the patient is right now. And while these may seem like semantics, I think it does have an important ability because it does talk to the determination of severity and it does influence decision making. We know as HPB surgeons that there's a huge number of publications over many years talking about the different classifications and stratifications of acute pancreatitis, and I'm not going to go into any of them, but I think what we need to understand when we look at those is that some of them talk to organ dysfunction, some of them talk to pathological changes in the pancreas or in the retroperitoneum, and we need to be able to distinguish between those. Now, I would say that over the last 2 decades, there's been an increased understanding of the pathology of acute pancreatitis, and this has improved to the point where I think many of these historical classification systems have actually become redundant, largely because they're either not user-friendly or they're not really focusing on the determination of severity at any moment in time. So this started when the authors of the revised Atlanta classification realized that the Atlanta classification had many gaps in its ability to be clinically relevant in the management of this disease. And as you know, they spoke about mild, moderate, and severe disease. But the authors of the determined-based classification felt that it actually wasn't probably adequately descriptive. They started to say that, in fact, there's only 2 things that determine outcome, and that's about persistent organ dysfunction or organ failure or infected peri or pancreatic necrosis. And that a range of combinations, and I think it's important to understand it because it's actually quite easy to understand. Mild is when there's neither. Moderate is when the organ function or failure is transient, but you may have peripancreatic changes. Severe is when you have either one of those two, and then when you have both of them, the mortality increases dramatically, as I'll show now, and that leads to a different outcome. So let's look at these, and I'm not going to go into any great detail, I don't have time, but what I want to point out is in fact, when you look at the reasons why that was important to stratify according to the revised and Atlanta classification, the second reason they give is that in a secondary care setting, clinicians need to identify such patients for possible transfer to specialist centers. So they're already making this assumption, and they're making the argument for me that while there are a whole lot of other reasons to use the classification system, it's important to recognize that transfer is one of the important reasons. So there are overlapping phases, and I think that when you look at the difference between the revised Atlanta classification and the determinant-based classification, you start to see that the Atlanta classification seems to suggest there are two phases in the disease. The first one defined by the inflammatory process, defined by a cytokine reaction, and that really gives rise to the systemic inflammatory response syndrome. The second one, which is slightly later, which is driven by the necrosis and in fact the complications of the necrosis. And I think that while the determinant-based may be important in separating out outcomes, I think that in developing a treatment strategy for the individual patient, we need to be still thinking about it in these two, in the context of this. And so it's about the complexity of doing that again, in my view, supports this movement or the transfer of patients. Now, the determinant-based classification came about after a significant meta-analysis was able to show that there are significant different outcomes when there's both organ dysfunction and peripancreatic or infected necrosis. And that in fact, when both of them exist, the mortality rate increases almost doubles. So it does add a lot to our understanding of the disease, but I'm not sure that it really makes a big difference when it comes to actually stratifying those patients who should be transferred or those who should be admitted to an intensive care. So there have been some studies that looked at comparing these two, and I think that certainly this study in 2016 didn't really find any major significant difference between the two. This study, which was a validation study, I think is where you can see the significant increased mortality in patients with a critical acute pancreatitis. So from that point of view, I think that the determinant-based classification is important because it does give us this important fourth category. So it's not just about the two vague terms. I think that the organ dysfunction needs to be unpacked, and how do we actually start to understand organ dysfunction? And you'll know that there are many scoring systems, Marshall, BISAP, Apache 2, just to mention a few. And many of those have been studied, and the way that they've been looked at is using this model of the area under the curve in receiver operating curves. And the area under the curve starts to talk about the ability or the point at which these become most accurate. And there are lots of studies that have done that, and I'm not going to go into them in any great detail. So let's look now at what we know. Where's the proof in acute pancreatitis? What have we learned over the last few years in terms of our management and how that applies to these particular group of patients? And I'm not going to go into them in great detail, but we know that things like steroids, platelet activating factor antagonists, somatostatin analogs have no real clinical application at the moment. Probably no role for prophylactic antibiotics. Early stenting of the pancreatic duct doesn't really influence the outcome. Routine endoscopic sphincterotomy in biliary pancreatitis not indicated. The whole issue around feeding and enteral probably being better than parental, and that no difference between nasogastric and nasojejunal feeding. Diagnosing infected necrosis can be challenging, but I don't think that the reliance on fine needle aspirate biopsies is currently the standard of care. Management of the infected necrosis should be delayed to allow demarcation of the necrosis. The management requires a step-up approach, and using this approach, a third of these patients are not going to require anything more than catheter drainage. and then the role of a whole bunch of minimally invasive approaches, which are not standard of care in secondary and district hospitals or primary hospitals. And so most of this should exist because the multidisciplinary team, as I'm going to show you now, really is important. So the studies, I'm not going to go through them, but they're all there. I think we all know them well, supporting much of what I've said, whether it's the step-up approach or really systematic review. So I think that the evidence for that is quite clear. So the management of the MAR group, appropriate at a district and regional hospital level, no debate. The management of severe and critical, I would propose that the value of the MDT, the multidisciplinary team, is really important. The intensivist, the interventional radiologist, the endoscopist, and the surgeons. And these are not often available at one particular regional or district hospital, and are often only available, certainly in my country, they'll only be available in a central hospital. So is there evidence to support the value of this very advanced ICU care? And I think there's a greater number of evidence developing. So this paper published in 2017, a very large prospectively analyzed data, lots of patients using all the new modalities that I've spoken about in a referral center managed in advanced ICU, and clearly in this study showed a decrease in mortality. This Australian paper, Tom, this is for you, really was able to show us as well that the mortality in a historical series was double in their current numbers and analysis using modern approaches, all focused on a major ICU. And therefore, they're saying improved ICU and hospital outcomes in patients with severe acute pancreatitis receiving modern critical care in a tertiary care center. So, what else do ICUs have to offer? And I think we have issues like the use of extracorporeal life support. That's certainly not going to be available everywhere else, but does it work? We know that ARDS in acute pancreatitis is a very high mortality. But in this study, which is a small study, and there are not many to be found, but I think it starts to make the case that you can salvage patients using ECMO when they have severe ARDS. This study, I'm not going to go into the details, but really what it starts to talk about is large volume resuscitation, who should get it and what the outcomes are and when it's of value. And that kind of activity, I think, requires significant monitoring, often in internal monitoring. And so I think that, again, making the case for an ICU. Now, this is a study that looked at intra-abdominal hypertension. We know that there's a range of categories of the severity of intra-abdominal pressure, from just the hypertension to acute compartment syndrome, being able to judge when an intervention should happen, when the patient's adequately sedated, and these figures can be believed, I think requires a good communication in the multidisciplinary team, and often is the source, certainly in my unit, of significant discussion as to whether this requires open surgery, particularly because we very seldom perform open surgery for severe acute pancreatitis. Now, I just want to talk a little bit about the moderate severe acute pancreatitis, because I think that sometimes this is actually the most difficult group. And the reason that this is the most difficult group is because I think because of the high morbidity rate, what it talks to in these patients is the ability of an institution to rescue a patient from a morbidity. And if you can't rescue the patient and you don't have the facilities to rescue them, that high morbidity is going to turn into mortality. So the question is, can we differentiate between those patients with moderately severe disease, so transient failure, who will go on to a later complication, and those that won't? And I would suggest to you that's probably the area that we're least able to define at the moment. So I think the cornerstone to improved management of patients with complicated, including moderately severe and critical acute pancreatitis is the multidisciplinary team with a whole host of modern approaches to these patients. But I think the one issue that is really difficult is the timing of your intervention. When necrosis is ready to be drained, when antibiotics should be used in the absence of a final aspiration biopsy confirming infection, I think those are challenging. And that requires experience, and it requires a team that can communicate very well. So there have been people who've said that severe acute pancreatitis has become an ICU disease. I'm uncomfortable with that view. I think the surgeon still has a role to play, although in many respects, it seems that surgeons are backing off from this disease. So can we improve our prediction of severity? Well, particularly in the moderately severe group, well, does the immune system help us? This is an area that my own laboratories are working on, and it's really to see whether we can use the analysis of an innate and adaptive immune response to start to consider prediction of severity and enhance it. We don't think it can happen in isolation, but can it complement what we already know, and so leading to a holistic approach to these patients. I think it's a very complex area. I'm not going to even go into it, but I think that progress is being made, and we are starting to understand how we can determine at a different level, looking at a different component, particularly the immune system, that we can have a better idea of what's going on. So I want to end by just showing you some case studies of iatrogenic injuries from interventional management of these patients. This is just 3 patients that I've selected. There are many more, but I hope to show you that what this suggests is that if you don't have the right people looking after these patients. So look very carefully at this one here, at this right kidney. It's about to be assaulted with a tube placed right through the middle of the kidney. It baffled us. How did that even happen? We couldn't imagine how that may have happened. You can imagine the outcome there. Look at this patient. Here, this patient's having the spleen attacked with a catheter pushed right through the spleen. So these things do happen, and they happen fairly often. And the last one I want to show you is really one that looks at this patient who developed an aneurysm after the with the acute pancreatitis. Let me just go back. You can see here is an aneurysm has developed around probably the splenic artery, and the interventional radiologist in this case failed angioembolization, and you can imagine for the surgeon what that must mean. So let me conclude by saying to you that I think that patients with mild pancreatitis should be managed in the community and should not be transferred. I think patients with moderately severe acute pancreatitis remain an area that I think is still difficult to determine, and I think that it's really about the timing of the transfer in these patients. But I think patients with severe acute pancreatitis must be transferred. We're able to define them, I think, with a good degree of accuracy, both in prediction and stratification. I think that recent developments in the management have shown that the treatment options have changed and rely on improved organ support and minimally invasive therapies. Treatment in high-volume units with experience will reduce the mortality rate and even the ICU length of stay. And I think the experience can reduce the negative consequences of modern therapies. So we don't like to stick catheters through the kidney, through the spleen, and leaving aneurysms unattended to. Thank you very much. Welcome you to Amsterdam for the next EHPBA meeting in 2019. Thank you.